Welcome to the meeting of the Health Overview and Scrutiny Committee. Could I have nominations for a chairman for this evening's meeting, please?
I'd like to nominate Phil Cunnington, please.
Do we have a seconder?
I'm happy to second that.
Thank you. Any other nominations? Okay, should we have a vote on, sorry, do you have a seconder for Morag? Okay, we'll take a vote then on Phil first of all, as he was the first nominations. Could I have votes in favour of Phil, please? Any against? Could we have votes for Morag, please? Okay, so Phil, if you could chair, please.
At least I've got batteries, so thank you very much. Good evening, everybody. Sorry.
I don't even know we're sat next to you.
That's right. So we'll take the agenda as read. Is there anything else I need for the agenda? Right, okay. So do we have any apologies for this evening, please?
Yes, Alistair Neil and Councillor Rowland is attending online.
That's all right. I'll do the minutes then. If there are any comments or objections to the minutes of the previous meeting, please raise your hand or mention it. Okay, so in that case, the minutes are carried. And then finally, are there any declarations of interest? Morag.
Thank you. Just a personal one, because my younger son receives care through the adult care here. Thank you.
Okay. Any others? Great stuff. Thank you very much. In which case, how are you doing, Adrian? You settled in, ready enough to take over? No, I know. I'll move forward then with the next item, public question time. Have we received any questions for tonight?
No questions.
No questions. Are there any questions in the room? No, there aren't.
No member questions either.
Okay. So on to the first item, which is NHS continuing healthcare. Thank you very much to who is going to be presenting this tonight. Is it going to be Sarah? Hello, Sarah. Nice to see you. Thank you for joining us. I hope that guitar's in tune. Like the rest of us.
That's the part B.
Do you have a presentation for us, or
I do.
What did you want to do?
So I'll bring up some slides, and I think they have been circulated in advance. And just to introduce myself, I'm the ICB Executive Director for Berkshire West Place within the Integrated Care Board Leadership Executive Team. And so I'm here today to give you an update on the work that's ongoing around continuing healthcare, in particular focus on the transformation work Bob-wide, but also some of the local work to address particular areas within Berkshire West. So I'll just share the presentation.
While you're doing that, Sarah, can you just tell me, do you mind questions as we go, or do you want people to reserve them for the end of a page or the end of your presentation?
I'm very happy for questions as we go. Whilst I'm presenting, I can't see any hands though, so Chair, if you could just interrupt me if questions are raised, I'm very happy to take it as we go.
Yeah, that's fine, thanks.
Brilliant, thank you. So I'm here to talk about the all-age and NHS continuing healthcare improvement work that we're doing at the moment within the integrated care system, which will also touch on joint funding arrangements as well. So that's arrangements where an individual may not meet the eligibility criteria for NHS continuing healthcare, but we may be looking to contribute towards an element of the funding towards their care in partnership with the local authority. So I'll talk a bit more about that as the presentation goes on. So just to provide a little bit of context, so the Integrated Care Board was officially formed in July from the merger of the three CCGs across Berkshire West, Oxfordshire and Buckinghamshire. And one of the pieces of work that we wanted to take forward very rapidly following the formation is around continuing healthcare, and a transformation programme has been set up to aim to deliver against a number of areas which are outlined on this slide. So making sure that assessments for CHC are occurring at the right time and place, really focus on reducing the variation, and this is really important. We want to make sure that there's a consistent patient care experience of CHC, both in terms of the assessment process that they go through and the eligibility and how the national criteria is being applied across BOB. BOB being Berkshire, West, Oxfordshire and Buckinghamshire, apologies for the acronym. And to establish a good level of ICB oversight and performance management around the deployment of this care and the funding, and standardise the corporate support services for continuing healthcare. So how can we do something once across the 3 areas to really streamline and make the service more efficient? And reviewing our commissioning arrangements, so driving economies of scale where that's appropriate, but retaining a real local joint working with local authorities around commissioning and making sure we're doing as much as we can in partnership when we talk about commissioning care. So I mentioned we've got a CHC transformation board that's been established, and it's overseen by our chief nursing officer, so very senior oversight, and it meets monthly. There's broad representation across the integrated care board, including a representative from each of the 5 local authorities. Matt Pope will come along as your Director of Adult Social Services, and I attend as well. There's 3 phases to the programme. So a comprehensive review of CHC services is currently underway, looking at what happens in each of the 3 areas, where are there variations, and what operating model might we want to employ going forwards, with an aim to address the areas in the previous slide. That will then turn into a development plan for implementing the recommendations from that review, with a real, again, focus on high quality, efficient, fair and equitable CHC services across BOB. And then looking at leadership and mentorship development for the individuals within the team. So that will follow on once we've confirmed the plan for how we're actually going to deliver CHC services going forwards. At the moment, in Berkshire West, the CHC team is an arm of the ICB, so that's something that's in-house. It's a team that is located within Berkshire West, and does work with colleagues in the local authority, but at the moment it's an arm of the ICB. I also wanted to note that there are some specific actions we're taking here in Berkshire West as well. Members will be familiar with an LGA review, a Local Government Association review across BOB in July, which identified a lot of areas of improvement, but with particular focus on Berkshire West as well. Some of the equity and equality of access was highlighted in that review as well, and whether there's inconsistency across the 3 areas. So we are engaging with the Directors of Adult Social Services, myself personally, with Matt Pope and his counterparts in the other 2 local authority areas of Berkshire West on a regular basis, including the external transformation consultants to work on. So what does this mean for Berkshire West? What are we going to do differently here? So our local action plan is looking at our CHC standing operating procedures to make sure that they are absolutely following best practice. We are working to agree a clear disputes policy that we don't currently have in place. So if there's disagreements, it's not always clear how we should resolve those. So we're going to make sure that we're all comfortable with the disputes policy that's in place, and target that by the end of this financial year. We're also working on a business case for the implementation of a kind of a joint funding shared care policy and pathway, as I've mentioned before, that makes it clearer whether something should be covered as a health cost, as NHS cost, or a local authority cost when we're talking about joint funding arrangements for individuals that need care from multiple agents. And we're working through the detail of that and ideally trying to align it with other areas locally that have things in place already. So how can we take the learning from other systems and implement that here? So the business case associated with that is being developed at the moment. And we appreciate that we want to do further work on improving the relationships and mutual trust between our teams. So as part of this work, we're not losing focus on that, and making sure that we can embed more of a sense of we're one team here working on behalf of our residents, and with that ethos in mind, go forward and do some team development work between ICB staff and local authority colleagues. And crucially, we've just agreed a new post. So we've got a lady being seconded in as our head of CHC, and she's from the NHS England central team and has an awful lot of good, strong knowledge and best practice around continuing healthcare. So she's coming in to provide us with some additional leadership capacity in this area to support the Berkshire West improvement plan, amongst other things that she's doing in her Bob-wide role. So I appreciate that's a bit of a whistle-stop tour as an update, but I wanted to be able to provide you with some assurance on the work that is ongoing at the moment, that this is a priority area that we're focusing on and very much approaching it in a partnership way of working, working closely with colleagues in Wokingham local authority to make sure we are able to deliver the best service we can on behalf of our residents. I will stop sharing my screen and just open up to any questions, if that's okay, Chair.
That's fine. At this juncture, if it's okay, I would like to hand over the chairmanship to our chairman, Adrian Mather, to continue from the meeting from here on in.
Hi, Sarah. Sorry, I was a bit late for the meeting. It's good to see you. Thanks for attending. Thanks for the description of CHC. I have a couple of questions around CHC. CHC, I must be honest, is a new term to me. What does a typical CHC patient look like, and what, how do we handle that kind of patient typically?
So it's so NHS continuing healthcare is where an individual has ongoing care needs that predominantly relate to a health issue. So there's not a typical person to describe. There's a range of health needs that may need to be met through continuing healthcare. It can be provided sort of care in their home, and it can extend to sort of nursing and residential care as well, a contribution towards that.
So is the primary deliverer of CHC the adult social care team in the locality, or is it somebody else, or is it a mixture?
So continuing healthcare itself is the assessment of whether of someone's care needs and whether they're eligible for continuing healthcare is undertaken by the NHS, so the Integrated Care Board team, who will then commission packages of care or commission the care from independent care agencies. Here in Berkshire West, we don't have a joint commissioning arrangement where we kind of work where we have one team commissioning CHC alongside local authority care, and that's something that we are discussing.
Apologies. I noticed that you identified that Berkshire West is a little bit behind the curve, should we say. Could you give me a bit more detail on that, and what kind of things you see there, and what is the action plan to recover the situation and bring Berkshire West up to the similar levels of the other areas?
So the Local Government Association peer review highlighted a number of areas, predominantly around relationships between health and local authority colleagues in this area, and it also highlighted a level of discrepancy in the level of provision of continuing healthcare per 50,000 population in comparison to other areas. These are publicly published statistics that Berkshire West has a lower level of provision per 50,000 area, which may be absolutely appropriate, but obviously we're looking into that to determine whether we are providing the appropriate level of continuing healthcare, and if not, what needs to be done about it. So that's part of the programme at the moment.
Thank you very much. Has anybody else got any questions?
Good evening. So the plan is focusing on reviewing our CHC standard operating procedures to align with best practice. How far away from best practice are we at the moment?
So I think the review is in progress at the moment, so I can't comment on the specific findings of that. I think that there is an awful lot of good practice underway at the moment, so it's how can we get more sort of consistency between the areas, so that where we can learn from the others, we can do, but not lose the elements of good practice that are in place at the moment. So I think once the review of our operating model has concluded, I'll be able to provide more specific detail on that and the particular changes that we're looking to put into place. At the moment, the external consultants are still working through a range of options for the operating model going forwards, and which would be implemented.
Could you highlight what you think's done exceptionally well at the moment here for West Berkshire? Sorry, for Berkshire West.
So I think we've got sort of good knowledge within the team. We've had some so from the view of the external consultants, and some of this is in the LGA review as well, around the in-depth knowledge of CHC legislation locally and the policies and procedures there that are required. I think some of the areas that we can work on is capacity within the team. Our team's quite small, and by nature that then affects working arrangements going forwards, and very much the working relationships and trust, I think, are areas that we do need to do more on between our colleagues here in the ICB NHS team and local authorities.
I think it was Rebecca next, please.
Sorry, I was just wrestling with the microphone there. So we're not far off March this year, about when you're going to report back with your strategic plan. How are you going to share that and show us the kind of progress that you've made with this?
So we have a meeting of the Transformation Board on Monday to review and make decisions. So I'd be very happy to come back to a future HOSC to provide further updates on that going forward. So I'm very happy to have as open a conversation about this as possible. On a more operational level, colleagues such as Matt Pope are involved in that conversation directly, and we have a regular meeting of him, myself, and the other Director of Adult Social Services from Reading and West Berkshire. So at that sort of day-to-day management level, we're constantly talking about it. But I'd be very happy to come back to this committee with a further update at your invitation.
Thank you.
I think Beth had her hand up on the phone. Are you there, Beth?
Yes, I am here. I haven't got my camera on because it's freezing cold here. I've no heating, so I'm wrapped up like a little doll. I'd like some clarification, please, on the relationships issue that you spoke about. Is it because all these organisations are new, the personalities are new to each other, and relationships and therefore trust has yet to be established, or is it something else? And you also mentioned inequities in funding. Could you give us a bit more on that, please?
Of course. So to your first question, I think one of the difficulties is where there are, whilst it's all public funds, there's criteria to meet to decide if someone is funded by the NHS or not, and therefore there's been some sometimes it's led to difficult discussions, difficult conversations around who should be funding care, and that leads to sometimes difficulties in relationships and a breakdown of trust. And I'll be honest, and that's the situation that I think we're facing between our teams here in Berkshire West. So some of the work is to build that trust back up again, which is helped by having sort of clearer policies and leading from the top. So Matt and I presenting a united front on a lot of this as well, I think is really helping. So it's more from that perspective that we're working on this together on. In terms of the second point, so we have a legal obligation to provide NHS continuing healthcare if someone is deemed eligible through the assessment criteria. So that we are absolutely doing that based on the kind of the assessments that we are referred to, which is called, we have to complete a checklist. If they are positive on the checklist, we then conduct a continuing healthcare assessment. The national statistics show that the total amount that we spend on continuing healthcare here in Berkshire West is lower. We're an outlier, it makes it lower. So that leads to the question of, is that because there's a lower need, or is it because we're not capturing all of the checklists that we need to be doing to make sure that we're providing the right level of continuing healthcare services? So that's all part of the work we're doing at the moment when we're looking at our operating model to make sure we are capturing everybody who needs to be considered for NHS funded care, rather than the kind of the cost of that care being borne by the local authority.
And there are inequities in that funding across Berkshire West, or I don't quite know what my question is here. It was the inequities that excited me.
So maybe inequities is the wrong word. At the moment, there's disparity. So this is monitored at a Berkshire West level because it's based on the old CCG footprint. And the national statistics monitor it by 50,000 population. And so there is variation between the level of funding provided per 50,000 population between Berkshire West, Oxfordshire and Buckinghamshire. So that is what we're looking at to understand what's driving that variation, and is it based on need, which will vary between different area, and make sure that we're confident and comfortable that we have a consistent approach.
Okay, thank you. When will you be able to come back to us with your further thoughts on that?
So I'm not completely familiar with the frequency of this committee, but certainly within the next 2 months, so in March, I think I'd be able to. Okay,
that's great. Thank you very much.
Yeah, I'm sure Sarah will schedule the right time with you. I think Phil was next.
Hello again, Sarah. Actually, I just wanted to drill down a little bit on what Beth was touching on. In as much as eligibility is low, you said, across Berkshire West. Well, we know that Berkshire West is a bit of a ragtag collection of different unitaries. I'm particularly interested in this meeting in the eligibility levels for Wokingham. Are they something that at the moment we should be concerned about?
Thank you. So I think I just want to be careful with the term eligibility, because if anybody is eligible, then they are provided with the funding. So it's looking at kind of the totality of who's receiving this NHS funded care. At the moment, it's monitored at a Berkshire West level. I don't have the Wokingham specific information to hand. We'd be able to drill down into that. I assume, and I can provide that separately.
Yeah, it would be great if you could bring that back in March, please. That would be very helpful. From personal experience in my family, I just wonder, are there any delays in the delivery of care whilst these assessments are taking place? And if that's the case, who pays in the meantime? Because there's got to be a default payer while you decide who's going to pay, if you see what I mean.
So at the moment, and one area of really good practice in Berkshire West, coming back to an earlier question, is there's a national standard around completing assessments for continuing healthcare within 28 days, and Berkshire West performs incredibly well against that, and almost all of our assessments are conducted within that time period. There are varying criteria for who pays for the care in the meantime, depending on how someone's referred in, whether they were receiving care beforehand. And that's all set out in a national framework around it. So we are following that framework in terms of who pays for care in the meantime. So they're not left lacking care.
Okay, thank you.
I think Rochelle was next. Thank you.
I was wondering, two of these organizations you're talking about are full county councils, both Bucks and Oxfordshire, and you're only talking about Berkshire West. Does Berkshire West, what unitaries does that include? And is there Berkshire East? And why aren't we combined together as Berkshire East and West to be equal to the other counties as far as population and funding go?
Thank you. So this is a question about the broader new NHS structure, and there was quite a lot of debate around how the geographical line should be formed, and it was sort of decided nationally that the local integrated care system that we sit within as Berkshire West, and I use that phrase because that's the health place terminology, is better aligned with Buckinghamshire and Oxfordshire. So we are now part of an integrated care system that comprises Buckinghamshire, Oxfordshire, Wokingham, Reading and West Berkshire, but with the acknowledgement that we are working very closely with colleagues in Frimley Integrated Care Board, which covers the east of Berkshire as well.
It's just that we're not equal then as far as that goes, because the other two counties have their full county in them. And if we're looking at population and funding and things like this, it's an unequal amount of split between all of us. And also the fact is that Woking itself is the lowest funded authority in the whole country as far as that goes. Famous thing that we've all used to hear very often in council meetings, but we'd like to know that we are getting a reasonable amount of funding in this area.
So the integrated care system geographical lines don't necessarily affect the funding provided, so that there is still a focus on sort of local authority areas as well. So I don't think I'm confident to say that by being within the BOB system as opposed to a Berkshire wide one, that won't have negatively impacted on the funding available in Wokingham.
Any further questions for Sarah?
Apologies if because I missed the start of the meeting, and if I ask a question that you've already covered, double apologies. So I've got three basic questions. So I can see the dates on the slide on the presentation and in the documents you provided. When will our residents start to benefit from this? That's question number one. When do you actually see it making a difference to the current assessments? You've mentioned a few times that you'll come back and report back to us or let us know what's going on. What is anything we can measure? Because at the moment it's all very descriptive of we're doing this process, this review. Will you have anything that we can put? I can see you smiling now. Is anything that we can put numbers on to show the progress? And finally, in terms of the change in how you operate and how you assess people, will these reviews and the disputes be backdated? Will people who are currently assessed as being having the care provided by the boroughs have the chance to redo their assessment under the new criteria? So that's the first question. That's the last question. Backdating. Thank you.
Okay, thank you. So, sorry, could you remind me of the first question?
I'm just wondering when residents will start to notice the difference, and outcomes will be different in terms of the care provision or the funding of care provision.
So, the first and third questions are probably quite a similar answer, in that we're not looking at necessarily the actual eligibility criteria for this funding, because that is set nationally. It's making sure that we are being consistent in our application of that across Berkshire West, Oxfordshire and Buckinghamshire. So in terms of who will feel the greatest benefit of this work, it's largely going to be the staff involved in the processes, who get greater clarity around the processes we follow in determining funding, rather than there being a risk at the moment that there is a significant level of care that is not being met in the community, because that risk is not coming through other areas such as safeguarding or other kind of safety nets that are in place that would be flagging very clearly if there was a big unmet care need in the community. So I'm not expecting a big impact to be felt by the public. This is more around how we are working as organisations. So in terms of measuring the impact of that, I think a big piece of feedback will be around staff feedback, the teams working in this every day. How is it feeling easier? Is it feeling less of a rub between our organisations? Is it feeling more collaborative and integrated? So those are the things that we'll be looking to monitor as well. And obviously, if funding streams do change, we'll see a difference through the national reporting around continuing healthcare funding per 50,000 population, if that is one of the outcomes that comes as a result of this.
Excuse me, Sarah, can I interrupt? It's Phil Cunnington again. As I said, I have experience of this, and I think that we need to be aware that the patient families and carers are quite involved in this process, and they understand that it's going on. And so I'm rather hoping that some of the stress is going to be taken out of this for them. So I think that perhaps I would hope there would be rather more impact than perhaps you suggested.
Okay, yeah, no, that is a very good point. I was thinking more from the angle of if there's care that's not being met at the moment, and I wanted to reassure members of the committee that that's not a risk that we are foreseeing. But you're absolutely right. The process of going through these assessments can be at an often difficult time for the individuals involved. We need to do what we can to make it feel like a smoother and more collaborative process. So I would expect that the feedback to be positive from the service users there.
So I guess from the point of view of the service users, for many of them, the best outcome is they don't realise that they've been assessed, or they go through the assessment and the NHS just carries on providing the care that people expect. It's the people who are not getting that outcome currently that I was thinking about in terms of the backdating of this review. Because if, for example, you're spending your savings or the value of your house or whatever to pay for care and to commission your own care that you may not have the experience of doing, is there an opportunity for those people to have the criteria applied? I think you use the word more uniformly, implying that currently they're not being applied uniformly. So is the chance for the reassessment of people? That's what I'm thinking about.
Yes. So if there's any sort of change in care needs, and there is a process for feeding back into the review process, those individuals will then have a review and reassessment undertaken, absolutely in collaboration with them as well. So that is a standing process to routinely review the care being provided and the funding routes available to individuals who are receiving care.
I'm not talking about a change in needs. I'm talking about a situation where somebody has been through the process and the way that the process has worked out for them. And we've already, I think, established that in this area, they had the least desirable outcomes for the residents compared to other areas. Do they, with the same care needs, get the chance to be reassessed and to be, I don't know what the right word is, recalibrated?
So I just also want to just clarify in terms of favourable outcome. At the moment, I don't want to make any, or I don't want us to reach conclusions around the kind of whether it's favourable or not. At the moment, it may well be that we are just there's a level of care that is being provided that is an appropriate level of kind of eligibility for continuing healthcare. So I just wanted to clarify that point. We're looking at it as we rightly should do. We look at everything, but I don't want there to be a concern that what we're doing currently is not appropriate. I understand your question. I think I'll need to take that one away to come back with you with an answer on the specifics, because I don't want to mislead the committee if something's not completely accurate in my response.
And any more questions from anyone? If not, then Thank you very much, Sarah. I know we've given you some difficult, challenging questions, as we always do. And we really appreciate your time. I believe from Madeline's comments that our next meeting that's pertinent for you would be the 27th of March, Monday. And we would really appreciate if you could come back on that date. I think Madeline will formalise that with an invite.
Great, very happy to. Thank you, and always happy to have this. This is what the forums are for, aren't they? To have these sorts of conversations. So I welcome it. Thank you.
Thank you so much for your time. Really appreciate it. Bye bye. The next item is Wes, I think. Before you start, Wes, I don't know if you need to share something or share the document or just talk through it or whatever, but maybe I can just firm up on the way this committee likes to work. So the assumption from this committee is that we read all the briefs, and that if you could direct us to the key points and go into a little more detail on what you regard as the key points. But I understand from the briefing I've had that this is really an initial autism strategy. So there will be some level of detail that you won't be able to go to. So as long as we can bear that in mind from a questioning perspective, I think we should have a good session. But I would like to hand over to you, Wes. Thank you very much for coming.
Thank you, Adrian. So my name's Wes Hedger, and I'm the Assistant Director for Commissioning in Adult Services. And as Adrian said, come today just to provide an update on where we are in relation to the autism strategy. And as you know, we have a duty around the autism strategy to produce a commissioning plan. And I believe there's been discussions previously around some work that was done in previous years to develop our strategy. And I think a big change to our approach and where we are was not only COVID and the pressure that put on the service, but the guidance that was released by central government in 2021 around the autism strategy and the approach and the desire to have an all-age strategy, which is supported across the whole system. And we've looked at that and we've reflected on that process, and what we're looking to do now is to proceed with those elements. So we have now moved towards a strategy, and hopefully this paper outlines our plan for delivering that. The big step for us is we recruited a permanent commissioning lead for autism. So we have a permanent post around autism, and she started in October of last year. And she's really started that process work in terms of developing our way forward. And what we have now, and Sarah's just left us, is a real ambition to do this together jointly with health, and work within the system to create that joint approach to autism. And also in terms of having an all-age strategy. A big gap in our previous approach was that it was very much focused on adult services, and we are now looking to have an all-age strategy across adults and children's services, and there is a commitment to deliver that all-age strategy within Woking. So the paper itself outlines timescales for delivery, and where we're looking to have that strategy in place, and we'll obviously with invite bring that back for further look as we go forward. The intent is to have the draft strategy completed by June, and then to move to executive for September of this year. Again, so really positive that we've moved forward in terms of having that system approach to autism and that all age focus on as an autism strategy. That's it, Adrian. So I don't know if there's any questions.
Bill, please.
Thank you, Wes. Just very quickly, this is the proposed way forward. Where would you say we are now? Are we nowhere, doing nothing, or what sort of level of provision do we have, or facilities are we offering currently?
I wouldn't say we're nowhere. In terms of our approach, it's very much working with the VCS and the sector around our offer, and having a joint approach to that. So the appointment of the current post was done in consultation with the voluntary sector, and they're on the recruitment process. And as the paper alludes to, we're looking to create an Autism Alliance, which really brings people together and supports us to develop that sort of smart action plan around delivery. So we're at the beginning of putting together this new age strategy, and that doesn't mean that there aren't things going ahead anyway. Another aspect would be co-production and how we utilise our approach to social care futures to support the development of the strategy as we move forward.
Rebecca, please.
Thank you. So you're saying you're hopefully going to have this strategy by June this year, and you've now got the lead-in role, and then that will be presented to executive. When will HOSC be able to have a look at that strategy, and when can we meet this lead person?
We always want to know before the executive.
So yes, we're happy to bring it before executive in terms of it. So it's due in June. That's our current timetable that we're working to. So from the period of June, we can bring that to the committee for scrutiny at that stage. In terms of the individual, I'm happy to arrange a meeting. Her name is Sophie Kendall, and I'm happy to arrange a meeting if you would like to meet her and talk through that, or she can obviously come here.
Jackie?
Yes, that would be interesting, actually. I have a severely autistic granddaughter and 2 young grandsons on the spectrum. So it's really pleasing to see that you've got an all-age approach. And the last bit here is reviewing progress and prioritising resources. I mean, the whole it's welcome news.
Andy, did you want a question?
I've got 2 things. First of all, I think you may have slightly misunderstood the point earlier about bringing the strategy in front of HOSC or this committee, because I think what these committees try to do is to look at items before they go to executive, so that if there are any suggestions or comments we can make those before, rather than just look at something once executive have already agreed it, because then it's too late. So it might be something we think about for March, if the strategy is ready for March before it goes to exec, because that's our next meeting. So I'm not sure we can sort it out in this meeting, but it's certainly something to take away, I think, for you to discuss.
I think as soon as is sensible, but before the exec.
So, sorry if I was unclear. That was my intent to say that I was bringing here before executive. So it's due executive in September. So the draft will be done in June, and I'm happy to bring it after that point. So apologies if I misspoke.
My apologies for not picking it up in the paperwork as well. Thank you, Alison. And so the second thing is, what sort of outcome will this strategy have? What difference will it actually make to autistic people and their families? Because I don't have any expertise in this, and I just don't know. There's a document. I just don't know what the outcome is going to be. The practical day-to-day outcome.
Sure. I think in terms of the strategy, what we're really aiming for is having a meaningful action plan as part of a strategy. So obviously it will outline the direction of travel, but we'll spend a lot of time developing our action plan with our Autism Alliance, which is the VCS, to come together with that meaningful, what does it make the difference in terms of that. And again, we also think what's really important is that this is a whole system. So Sarah, again, the commitment that we're working with health around assessment process, etc. And that's going to be the meaningful thing that makes a difference, is going to be this action plan. So we're right at the beginning of the journey in terms of putting the strategy together. What we do know is, again, in terms of having an Autism Alliance, that's a benefit straight away. That brings together the VCS and all the people that are working to support autism together to have that single voice and direction of travel. I think another really positive thing about the way we're going as well is around co-production, really engaging users by experience in the process of developing this strategy will be a really strength of it. So what makes a difference to people will actually inform that action plan that comes out at the end.
So then my question would be, what sort of things do you expect to see on the action plan? Because at the moment I'm still no clearer as to what benefit it will have to people with autism and their families. And I'm wondering, perhaps are there examples of local authorities which perhaps already have such strategy in place? How are they doing things differently to what we are already doing? I mean, I don't want the whole story, but just some examples, please.
I guess the main thing would be a whole age approach to autism, as we were discussing earlier. We see there is a real divide in terms of autism for a young grandson and an older adult, and hopefully this strategy will give us a whole age approach to people with autism.
So I'm still really struggling to understand, how does that make a difference? I mean, what will be the change when somebody with autism or their family interacts with one of our officers or one of our teams? What difference will they notice?
So again, in terms of the specifics of what come out of the strategy, I can talk about principles. So again, in terms of grandson going through the system, obviously transition to adulthood is a national issue. And around how you support people transitioning to adulthood. Again, our strategy will look at that transition process and support people who are transitioning with autism and those eligible for care and support them going through. So that would be a positive thing. Again, the whole system approach to the way in which you're assessed in terms of having autism, and as you'll know from your grandchild, that takes time, and we will be looking to support improvements across the whole system. So we have a very disjointed system at the moment, and this will be looking to bring that all age, all system together.
If it's okay with Andy, I'd like to move on because we've got 4 people waiting. I think Alison is next, and then I've got Morag, then Beth, then Rochelle.
Okay, Wes, I'd like to thank you for coming here in person. We really appreciate it. I think we have a much better dialogue, so thank you for that. Andy, I think what would have helped all of us is if we could have seen the draft autism strategy that you agreed back in the summer of 21, because most of your paper sort of refers to that and the work you're building on. Well, we haven't seen that, so we don't know what it is. And looking at the autism strategy is something that we've had on this committee's forward programme for quite a while. 2 years. Yeah, I knew it was a long time. We have a packed agenda, but also I suspect it was because we were being told by officers that, oh no, we're not ready to bring that to HOSC yet. So if it would be possible to circulate that strategy, so I think it'd give us a lot more insight as to what it is we're talking about doing. So that was my first point.
So the draft strategy itself wasn't completed and signed off internally because of those shortfalls that we talked about in terms of not being an all-age strategy, and that was really feedback from the sector and families as well, is that they were wanting that all-age approach, and we missed a bit there. In terms of the timescale, it did take too long to get to this stage. I guess just transparently, openly, I mean, we had resource in the council to support the delivery of that. In terms of COVID, that resource was diverted to support some of the response around that, which put a delay on the delivery of the strategy. So what's different now is, again, we've recruited permanently to support the delivery of the autism strategy, and hopefully that will progress it in a more timely manner.
Okay, I had no criticism of the timeline. I understand the difficulties you've had with that. But my main point is, can the committee see the draft strategy that you got to? So then I think we'll understand what you're working on, and it will give us more insight for when you come back later. My second question is about how do you have proper involvement, engagement with our autistic residents, because I think it's so important, especially adults, that we're talking directly to them. But how can you identify who they are and reach out to them?
So we're hopeful in terms of the Autism Alliance that will support us to engage individuals who are accessing services through the voluntary sector. We also have our Social Care Futures programme, which is really positive in terms of the way in which we're working with people within the community. And those two things go hand in hand. A key part of our autism strategy will be building on what was done before in terms of co-production. But again, in terms of that original document, it was not something that was completed to be circulated in terms of we weren't happy with the finished product to move forward with it.
I think I've got Morag next.
Oh, thank you. It's just a quickie, if I may. Are you planning on involving schools as part of the all-age strategy?
So yeah, we will look at how we engage with, because again, we weren't an all-age strategy previously, so this is a new addition to where we currently are. We'll look at that. I think it's important to work with schools, but also send voices and make sure that we get input across children's services in terms of development of the strategy.
I think Beth is on the phone as well. Beth?
Yes, I am. Thank you, Chairman. I'd like to take Morag's question a bit further, because as a school governor, pupils with autism present us with huge problems with resources being scarce and any health programme not being involved. How are you actually linking up with the education department or directly with schools? I'm sorry that your answer didn't really satisfy what I wanted to hear, because that for our young people is essential.
So the development of the strategy will be, and again, so we're at the start of the journey. So the development of the strategy will be done in partnership with Children's Services. There'll be a strategic lead from Children's Services at assistant director level who will support the development of the strategy. It will be written together in partnership across Children's and Adult Services, and we'll work closely with them in terms of the development of it going forward. But again, in addition to schools, we believe it's important to engage with other areas of children's services, including Send Voices, and make sure that they're a key part of the engagement, and other voluntary sector groups in terms of autism. But we will do that in partnership with children's services and make sure that we engage the right people.
You said we will, not we have. Have you
Yes,
not spoken to those departments already? I'm not sure when you started the strategy.
So the lead has been in post since October and is newly recruited, and we're at the beginning of the development of this new autism strategy. So we will is where we are at the moment, and we will work with Children's Services. That engagement activity hasn't been done. As I said previously, the previous iteration of the autism strategy was an adult services focused strategy, and we are moving towards having an all-age strategy.
I'm sorry if I sounded a bit impatient, but October was 4 months ago, but thank you for that.
Thanks, Beth. Rochelle, I think, was next.
Well, I have experience living with somebody who's neurodiverse for almost 22 years, among other things. But I'm just wondering, have you consulted autistic people as well about this, as well as just talking to all these other groups that take care of them or do something with them? But have you actually run it by people who are neurodiverse to say, is this going to help you at all or not? And if it's not, why are we bothering to do it? Why don't we do something that will help them?
Yes, we've done some engagement with people with autism. Again, this is an autism strategy, and we will state our intent around wider neurodiverse diagnoses, but this is around autism, and there has been some engagement. Again, I think some of our gap as it stands at the moment is specific around children's services, and we will move forward with that. But there has been engagement activity, yes. And also, as I say, we have Social Care Futures programme, which we will work very closely with.
Alison?
So I haven't seen them, but perhaps I've missed it. Have we had any comms going out on, we've got Great Borough Facebook, which, asking, are you autistic or do you have a family member? Would you like to get involved and have your input to our strategy that's evolving? Because as Raquel said, we have autistic residents who may not be part of a group or receiving care, but I think they've got very worthwhile input to this.
So engagement activity has been completed to date. I can provide the numbers back in terms of our reach. I don't have that to hand, but how many people we've engaged with. We can obviously look at that again and see if there's more that we can do. So there was, in terms of adults, there was some engagement activity. And again, some of that engagement activity highlighted the lack of all age approach. And that's why we're looking to expand it into that area. But if the committee wishes, I can provide data on how many people we've engaged with.
Yeah, I think at the next meeting, at the very least, you should come back to us on that topic. Bill?
Yes, just very quickly, I've noticed that the 3-year strategy is to cover the periods 23, 24 and the following years. Is that, apart from obviously the cost of the lead, is there a budget that goes alongside that strategy? Because that will obviously be in the proposed budgets for the next 3 years now. And what is it?
Phil, there is a very small part in terms of very small pot makes it something insignificant, but there is a pot of money in relation to co-production attached to the strategy as well, and supporting some of the Autism Alliance. I think it's about £5,000. It's not significant, and that's to support some of the aspects around the user by experience and how we support people engaging further going forward. But the post is the main expenditure on this.
Okay, it sounds, what I'm going to say now makes it sound like it's a trick question, but it really wasn't. It's because I have experience of somebody who was only given an idea that they may be autistic when they were in their 30s, and that was when they went to get some mental health treatment. And when they were doing the CBT was when it became quite apparent that there was a problem there that had been left undiagnosed. And so I just wonder how we're going to put a budget together which might allow for the fact that with the right amount of engagement with the public, we're going to maybe uncover people who will get very welcome support that is well overdue, but it's going to require some funds from WBC.
Yes, that's a really valid point. I think as we develop our smart action plan as well, we'll be able to understand what the level of investment is required to do that. We are looking at our MTFP in terms of the budget and what resource across adult services and children's can be allocated to any additional investment that is required. We're just not at that stage yet, Phil, in terms of what we need.
Any further questions from anyone? In that case, thank you very much for helping us through that topic. And we look forward to the next meeting, which will be June, will it? We could do July would be better. So if Madeline could coordinate that with you, then we would be very pleased to see you again in July. Thanks a lot for your time, Wes. I think the next topic is Health Watch. Is Alice there or somebody? Or hey, Alice, how are you doing? And Sarah, hi. Hi, Sarah. So just to reiterate, the assumption from this committee is that we've read your report. So you don't need to go through it verbatim, but if you could just draw out the necessary highlights as you see it, and we would then try and ask you some Q&A at the end of your presentation, if that's okay.
Yes, of course. Yes.
And thank you very much.
Thank you. Yeah. So really just to say how we approached our work plan. You'll see that it's probably a more extended document or a different document than perhaps was previously brought. What we have done is take the objectives of a Health Watch service and put them in, because there's a lot of work that goes on that we do day to day in engaging with the public and talking to people that doesn't make it into those sort of key priority headlines. So really what we wanted to do in our work plan was to really demonstrate the scope of the work that we're doing and bring in all the other facets of it. And then, of course, we've been working over the last few months to bring on board staff, advisory group and so so on, and find out what's going on. And then we've just arrived at a few shorter, not so extended projects of priorities and things to look at for the next couple of months, and then review it again as we move forwards with our new advisory group. So Alice is just going to run through our main priorities.
So thank you very much for having us. So you've seen our priorities, and you've seen that we are looking at recruitment of volunteers. Volunteers play a big part in our priorities. They are the ones who go and get the feedback along with our teams. And the other one that we are doing is also enter and view. That is based on feedback that we've had from the public. So we are going to be visiting one of our local organizations and view what the patient's experiences is, and then come back and do a report and share. Possibly we'll share with you all when the report is ready. Then our next one was looking at working with Healthwatch England. So they had a campaign about maternal mental health. And so we followed that through. We wanted to see what is our experience locally. So we are doing that with Healthwatch England. So we will bring that to you all as soon as the report is out on locally as well as nationally. The closing date for this survey is on the 27th of January, which is end of not long. Then we're also working with Building Berkshire Together. They are going around different boroughs to have a conversation with the local community to turn around and find out what is their views about the new build. And so they'll be soon be coming down to Wokingham, and so we'll be helping them to do some engagements. Then the other one that we are also looking at is the jointly planned and presentation of sessions on self-neglect, that is to the local voluntary sector with the West of Berkshire Safeguarding Adult Board. We are also looking at how the other work plan is looking at specialist health support for people with learning disabilities. And then also reviewing. While we were designing all this work plan, our work plan sort of priorities changed because we've had loads of feedback about certain vulnerable groups in Wokingham, and this the group that I'm going to be talking about is about the asylum seekers who are in the Home Office contracted accommodation. We've had feedback about their nutritional meals, about being isolated. So now we are working with public health to see how we can get their their experiences better in this accommodation. So our watch list, I think most of you are aware of the watch list about GP access. So we are working with the PCNs to try and see how we can get the connection so that the community can get the right messages, how to self-care, as well as looking at the new way of working to help the PCNs or primary care network to manage their workload. Then thank you. Last week I came to the dentistry questioning, and we've learned a lot from that, and we're now also sharing that information that you all shared to the public as well. We also, nationally we hear a lot about maternity, but at the moment we've not had any feedbacks about many people's experience. So that's on our watch list. Then cost of living. So Healthwatch England is doing a campaign soon about cost of living, about the impact on access as well as physical and mental health. So we'll be joining them to do this campaign as well. We also, you just had Sarah Webster talk about connecting healthcare. So we'll be part of the Bob IC ICS looking at this program as well. We are also considering to look at, we've been part of this carers partnership, and we are looking and seeing how we can get the other outside caring through provision of respite and other support services. And mental health for young people is also a priority as well, one of our biggest priorities, because we know during COVID, they struggled with mental health. So those are our watch lists at the moment. If you've got any questions, we are happy to answer.
Rebecca.
Thank you. I don't know how you felt after last week's HOSC and the dentistry session. I must admit, I came out thinking, not feeling incredibly positive at all. So, I read that it's good to see that you're targeting it and it's on your watch list, but you say about escalating it, because personally, I just came out of it feeling that we're in a pretty dire situation locally, and we've, as we know from Andy, local services being closed down for NHS patients, and without regular yearly dental care, the only service available, it appears now, on the NHS is emergency. So, I mean, how do you feel you can escalate it to see if you can make any difference?
So thank you for that. One of the things that we have done, so whenever we've had feedback about dental services, so we've had clients come to us and say they're struggling, and we have been trying to help them. So we had someone who came with who was vulnerable. We connected them with the community dental services as well. So we've supported them that way. But also the other thing that we also do is to support them. We also turn around and tell them what the processes are about dental care. To escalate, we also escalate to Health Watch England, who have collected from 152 health watches, and have been speaking to the Health Select Committee. So it's been escalated that far. So, so whatever feedback we get, we do escalate it. So that's how we've done with dental care.
Bill?
Hi, Alice. Thank you for this report. This is more like the sort of report I would like to see, although I'm just going to borrow my Andy hat for the moment. Can we assume that we're starting from a zero base? And will there be some numbers to substantiate your incremental improvement as these reports go on?
The one thing that Health Watch, when we started as Health Watch, one of the things that we have been asked to do is look at themes, not numbers, because themes do make a big difference. Is 5 people's experience is more valuable than hundreds. So because they have taken time to come and share their concerns. I mean, we also know that a lot of people don't like giving feedback because they do feel that their care might be impacted. So, it doesn't matter whether it's 5 or 100, there's still themes of care that needs to be looked at, or services that need to be looked at.
Yeah, okay, I understand that. But one of the things that you say in how we will check that we are successful in Objective 1 is numbers of people contacting Health Watch Wokingham. So I would hope that we will see some numbers attached to that, and so that we can actually get an idea of the level of engagement that you're managing to achieve.
We provide that data for Woking Borough Council on a regular basis, so we can share that. And of course, we'll bring the annual report in July when that's published, and that includes all the numbers in that too.
That's great, thank you. Then just one other question, if I may, very quickly. Where are you? You said that you're recruiting volunteers. Is that an unending quest to recruit volunteers, or do you have a target that you're aiming for that you hope to get to that you can report to us?
So at the moment, for example, our advisory board are volunteers. So we've now got 5 advisory board members, and and at the moment we the normal volunteers, there are about 3 so far, and I know we're all struggling with trying to get volunteers. Well, it'll be an ongoing thing. We are hoping to be at the volunteer fair this Saturday to try and recruit. But one of the things I would say, since after Christmas and the New Year, we've had quite a few people interested in wanting to be volunteers. That has been quite good for us.
That's great. Thank you very much.
I think Beth is next on the line.
Hi, Beth.
Yeah, hi, Alice. Alice, first of all, a thank you. A charity that I'm involved with has been able to provide cash for dental care for an asylum seeker that you found a dentist for. And that shows that we're working together, and I'm very grateful for that. But my question was on asylum seekers. I heard on the radio this morning that asylum seekers that the government have put into hotels can be moved without notice, especially young people, and no one knows where they are. Do we know who is actually in the hotels or wherever they are that we're looking after? And are we advised by the government that A, they're coming, and B, that they may have gone?
This is quite difficult to answer, because one of the things that it has been perceived that this is a Home Office issue, and it's a Home Office that deals with hotels. Or I mean, I one of the things that I do say, Beth, we try not to use the word hotels, because because people have this perception that they are in a comfortable situation, in a comfortable environment, and what the environment they are in is not a comfortable environment. So in that point of view, it is quite difficult to say. But however, can I just say that the Wokingham Public Health has been amazing, and they have been, even though Wokingham Council has nothing to do with the Home Office contracted accommodation, they have stepped up in a big way and to help them in any way possible. I'm sure Ingrid is coming to answer that question as well, to turn around and say, but they have helped with translation, they have helped in any way, they've helped with the GP services, getting them as much support as possible. However, they've also had barriers that has been difficult to overcome, and that's one of the reasons why we have also we are also supporting them to try and help break these barriers. And just to share as well, this is not this is a Berkshire West issue. It's also in West Berkshire, it's also in Reading and in Wokingham. So what we have done is there's a report that's going to come out soon in West Berkshire, no pressure to Sarah, that we are going to share the recommendations to the council, and the council, we are hoping that the council will look at the recommendations and see how we can make the service better. We are also in conversation with contracted providers to try and see whether we can close the barrier, close the gap. But I'm being honest about this. We are going to struggle, because they are saying that it is a contract, what they're being contracted to do. Especially the public health has looked at communal areas, and they've turned around and said, well, we've been contracted. We don't know to allow them to be in the room. So there are quite a lot of barriers that we need to overcome. And so, just watch the space, so you never know what will end up happening.
Oh, thank you, Alice. Perhaps we should say accommodation rather than hotels. And I'm sure between you and Ingrid will sort it out with Sarah and all the rest of the team.
Yeah.
Thank you.
Thank you.
Ingrid, do you want to say something?
Yeah, sorry, Chair. So I was just to specifically answer the councillor's question, which is that we do know who comes into and out of the accommodation for asylum seekers. We aren't always confident that that information is as timely as it should be, but we are, with putting quite a lot of pressure on the Home Office, we do get information about who is coming and going. There's relatively little coming and going, to be fair, from our accommodation in Wokingham, but we do press for that information. And otherwise, I would just echo what Alice said. We are working tirelessly to try and address the significant issues that that population is facing, and the barriers are around that national commissioning structure of that sort of facility across the country, and it's difficult, but we are doing our utmost to make inroads.
Thank you, Ingrid.
Thank you very much, Ingrid, and thanks for all the help that you've given to Health Watch, etc. Thank you very much. Any further questions? Andy.
Thank you for that. I've got two questions really. I think the second one is probably for Ingrid, so if she could hang around for 2 seconds, that'd be great. So I'm just sort of looking at page 8 of the report, and it talks about the statutory power of Health Watch to enter and view.
Yes.
And you talk about concerns have been raised about a provider, and I just wondered if you could tell us what sort of provider. I wouldn't expect you to name the place or the institution, but what sort of provider are we talking about? And then secondly, how does one, how does it get onto your radar to the degree that you think, oh yeah, we need to go in there and have a look? And that's my first question. So, and then the second question is for Ingrid, and just again going back to the issue of asylum seekers, and we've seen the awful story coming from Brighton, where children have gone missing. And I know, Ingrid, you've said there is very little turnover, and my understanding is that the guests we have do not include unaccompanied children, though I may be wrong on that. And I'm wondering if the Home Office decides, well, actually, we don't really like putting unaccompanied children in Brighton, and we're going to put them somewhere very nice, like Wokingham instead. What planning or provisions will we make to make sure that that sort of thing does not happen here on our watch? It's a very hypothetical one, I'm thinking. Yeah. So there you go. Thank you.
Ingrid, do you want to answer yours first? And then
I'll answer the second one. Thank you, Councillor Croy. So I think that there is a concern generally about the provision of the asylum accommodation, about what might transpire in that circumstance, given the lack of transparency around residents and the situation in there. So I think that, so just to say that we are working on that proviso of a raised index of suspicion, that there may be issues that we need to address. We have a structure internally in the council, so I'm not responsible for the asylum. I'm responsible for the health and well-being aspect of the asylum population, but we have one of the ADs from housing and community, Zulfikar is called, who runs the task, the sort of silver structure around the asylum hotel. So that is a structure that has representation from across the council, from safeguarding, from housing, from all of the relevant fields that you would expect to be scrutinising and looking at the issues in that circumstance. So and we're there, as I say, from health and wellbeing's point of view. So the largest area of risk around that is lack of transparency. So as soon as we know anything, we can obviously act upon it, and if we knew who was coming, etc., we would be able to put a lot of our plans in place. We have all of the right people at the table. So really, Zulfikar and others are working with the Home Office to try and increase that level of transparency, to try and find out what is going on at any given time. And we do have some powers to visit the accommodation through environmental health, for example, and other facilities. So we are doing what we can and working with the information that we have. So that's how I would reply to that.
Budget manager.
Thank you. So, thank you very much. And yes, of course, I should have realised there's another structure. So that was the second part of my question. The first part was for Healthwatch, because it's their report which talks about the enter and view and their statutory power to enter and view.
So we have two statutory powers, and one of them is enter and view, which is whereby we can visit any organizations that the public funds are put in. So so one of the things that we've had during our time, when I started, that we've had one particular organization or service that was the community was sharing that they were not happy with the service. And then we've also had a conversation with the Care Quality Commission as well about this organization to see what their view is. And our enter and view is very much like we go and find out from the service users their experience of that service providers or that organization. And that's how we do it. And all our enter and view personnels that go in are trained personnels who understand how to ask. So it's an interview. We do it as an interview, but we also do it as a survey that is put on our website. And also, we also give, we know that the community will not give honest information in that premises. So we are also doing another way of asking them to ring us or contact us differently. So that's what we are doing. But a lot of our it has been feedback that has been given to us by the public.
Thank you. So if we can talk hypothetically, let's say we have a care home and it's called Shoot End Care Home, which is here, and people have concerns about Shoot End Care. Be careful what I say. Shoot End Care Home, and there are concerns. When you come in, you interview the residents, or you interview the whistleblower, or
well, no.
And so just talking about, and how does that? Why wouldn't someone just go to the Care Quality Commission and get the CQC to come, or would they not do it directly from the public?
So one of the things that Healthwatch is part of the care. We work with the Care Quality Commission. We are the brother and sister of the Care Quality Commission. So we work together with them. So whenever Care Quality Commission representatives go into any of these residential areas or any of the organizations, they will always come to us and ask us, have we had any feedback? So it's the same way we will turn around and go to them. But because we have a statutory powers, and also we are about the public voice, so that is one of the reasons why we have this power to go in. So that's what tends to happen.
I think Wes wanted to make a point as well.
Yeah, I would just say in terms of the different roles, so we have a care quality team within adult services as well, which is very much that layer below CQC around compliance, around legislation, etc. So we have a very proactive care governance team which would do the policy checking, etc., which supplements the work that's been done by Healthwatch.
Thank you.
Alison, would you like to go next, please?
Well, I do have a question, but so would Healthwatch alert you that they'd received concerns from the public so that you'd be able to send your team in?
So we meet regularly in terms of the contract management process, and we have constant dialogue with Healthwatch around that. The care quality team is driven by a lot of different elements in terms of flagging particular areas of concern. That may be a safeguarding alert through to health feedback from Healthwatch to the engagement that they have regularly with CQC around what's working. So they speak very regularly with CQC on a very collaborative way as well around it. So where they're targeting their resource will be based on a number of things, and the care quality team is very active in working in terms of looking at elements of quality of provision.
Can I add something else in the sense that the consent, we go in only also after discussion with the care quality team. So if they say yes, it's a good idea to go in. So we need, whenever we do an interview, we have to justify why we are doing this, because when we do the report, it has got an impact. Because we can because it's about the public voice. Our reports are important, and we need to publish it of the report. So we do work with the Care Quality Commission, and also if we have, for example, any concerns that we hear from the public, we do go to the Care Quality Commission and tell them, and then they can also, make a decision of visiting the organization without unannounced.
I think Jackie's next.
I said I did have a question, but I'd just like to follow up on from the previous question. Overview and Scrutiny management have reached out, and we're asking everybody, all of our residents, what they think our committees should be looking at in our next programme of work. So I'd like to ask Health Watch what they think this committee should be looking at over our next year's forward programme.
I mean, the thing that one of the things I would turn around and say is looking at the things that we have just presented, in the sense that looking at what is mental health like, especially for mothers, because we've not really looked at that at all for a while. And that has also might be looking at, I think you've had maternity come and visit and share with you all their work, maybe reviewing that again, because we've also had a lot of things in the national news about the safety about maternity, and and what they have done for them. Because one of the things that's also happened is when you look at the Embrace report, which is about confidential maternal death, Black women are dying 4 to 5 times more. Asian women are dying. So, that's one of the things that would be nice to understand what they are doing for them. So that's one of the things I would say. And the other one is also looking at how the GPX, issue of the pressures of work for them has been, and how to make it better for the community, because there is some work that we could turn around and do to educate the community a little bit better, of trying to be a bit more resilient. Is one of the things I would suggest.
I just add to that in terms of communication. A lot of the things we see and the questions that we ask at different meetings, things are being discussed, but they're not being fed down to the public. So we're often asking the question, how are you going to communicate that with the public? And it's not a single issue thing, it's across the piece. One of the big ones that Alice has mentioned, and we've mentioned before, is the self-care elements, the changes in primary care. So you don't expect to see a GP, and you don't expect to see them face to face. Those kind of communications, that's just one example of where that information filtering down to the public in a way to understand. There's often a gap there.
I think it's Jackie next.
Thank you. I'm a bit confused. So you're gathering this information to make a report eventually to make something better, is that right?
Yes.
Yes. Okay, so these volunteers, how do you gather the volunteers? How are you getting it out there?
So we've been attending events whereby we can get together.
Attending volunteers. What? Attending
events. Whatever. Yeah.
Okay.
Events.
Right. Well, I have a specific sort of query or worry. I happened to randomly meet 2 Iranian people on last Thursday. It was quite dramatic. They have been in a hotel in Reading. And of course, up to now, I'd not even thought about it. But since I was introduced to them and I was asked to help, which I doesn't need to go into, they've been there for 18 months in this one cramped room with no ensuite or anything. So, and their health is really poor. They're only 40 years and 38. The wife has got a heart condition, he's got a stomach condition, blah, de, blah, de, blah. So are you saying that the Home Office doesn't tell us that Mr. and Mrs. whatever they're called is arriving at Mercury Hotel and we're going to monitor them? Is that right? So all these people are coming here and nobody's giving you the name and saying, can you watch over them? Or they've got a doctor. I mean, I happen to know these people who've been walking into the Royal Berkshire Hospital and getting it that way. And they are really poorly.
Mm-hmm. I mean, that's one of the reasons.
Is that what's happening? Right. Well, it's shocking.
That is one of the reasons, Councillor, because we have been alerted to all this. And so, and that's one of the reasons why when West Berkshire publishes the data, so the report, we will take it forward. But however, one of the things I have done, or has Healthwatch has done in Reading, is also escalated to the ICB and also to the ICP. So we've escalated that far. And also in Reading, we've also escalated to the council as well. Councils are aware of the situation. So we are trying through health to try and see whether we can make things better. But I will say that in Wokingham, the situation's a lot better because public health has been involved and they have been monitoring. The one thing that hasn't happened is the council has not been involved in Reading.
Sorry, so wouldn't it make sense if we know people are coming to a certain hotel, because these people aren't the only ones at the Mercury, Sindlesham Hotel, shouldn't we have a list who they are, their names, and then, I don't see how it's getting lost and it's getting worse. And
so yeah, let me probably just intervene. So there is a medical provision is commissioned for all asylum seekers in accommodation in the UK. So that is done through health. And in Wokingham, that's done through Amit Sharma's GP practice. So all of our asylum seekers in the Sindlesham Hotel are all part of Amit Sharma's GP practice, and he does deliver a health check for everyone that arrives in Wokingham. So, and we work with him to make sure that has happened. Now, different local authorities address these things in a different way. It is fortunate for us, I think, that Amit has agreed to take all of those the individuals in the asylum accommodation under his practice, so that we can work with one PCN clinical director and make sure that all of these arrivals get the best care in terms of having that initial check, understanding pre-existing health conditions, getting initial prescriptions of blood pressure pills or whatever ongoing medication they might be on, but also so that they have a point of contact for health should anything happen acutely whilst they are here. In order to facilitate that, as Alice has said, we have done translation of multiple documents to help them navigate the health system in the UK, provided information in different languages, just in terms of maps of how to get to the practice, all sorts of practical things to make that happen. How that works in other local authorities is different and a matter for them to decide. In terms of getting a list of who comes in and out, we don't tend to get that. So Amit will know when there is a new resident, because that will become a person on his patient list. But we don't get a list of who comes in and out. But as I said before, the change of residents, and you're right, these were set up as accommodation for short-term accommodation, and a lot of these people have been in this accommodation for over a year now, which was never the initial intention of that provision. So there are significant issues around being that kind of socially isolated and having that level of that kind of accommodation with no recourse to employment and all of the other things for such a protracted length of time. And that's something that we are both working sort of with the community at the accommodation, but also lobbying hard towards central government to try and change some of that policy for this community. But yes, we don't get this kind of list of who's coming in and out, but the population change is relatively small in Sindlesham.
Rochelle?
This may be an unusual question, but isn't Alex Sharma the MP for Reading West?
There's a doctor,
There's a doctor as
GP.
well,
There's a GP.
with the same name. I was just curious. Amit. Sorry.
Amit.
That's what I could hear from. I couldn't hear that well from you. But is this doctor in Woking or Reading?
Woking.
Okay.
Woking. Yeah.
Just making sure. That's all. I was wondering what was going on. It just sounded a little unusual.
Apparently he's in Brookside in early practice.
Mm-hmm.
Any further questions from anyone? From my side, huge thank you, Alice. Huge thank you, Sarah. So many good things to say. You've recruited some people. You're getting some traction. You've identified some very good themes, priorities, and the watch list, I think, is absolutely right on the money in terms of key topics you should be looking at and investigating. It's also great to see you working with Woking Borough Council, Ingrid, and other people, and really rolling your sleeves up and doing lots of things. It's really wonderful. Thank you so much. One question from my side. We went to the Bob Hosk meeting, not Bob Hoskins, but Bob Hosk, and there is a very strong push from the chair of Bob Hosk to really engage with Health Watch at the Bob level. Now, in Bucks, they have a single Health Watch. In Oxfordshire, they have a single Health Watch. In, let's call it West Berkshire, Reading, Woking Borough, we have different ones, but you're all part of the same organisation. So just a quick takeaway, just for something for you to take away and think about, is what would it look like if you needed to engage at the Bob Hosk level across Reading, West Berkshire and Woking? And that's not an answer I need now.
Oh, no, I can talk to that if you'd like me to. Something that I've been very involved in. Essentially, yes, as Five Health Watch, we are working together within Bob. We are representing the public at various Bob boards, committees, and so on. What we found is that some are quite happy with essentially five Health Watch going along and participating. Some boards have asked for just one representative from the five. So in those situations, and we met earlier this week as the five to discuss a meeting that's coming up, an ICP board that's coming up on Friday. So we share the papers, we talk about it, and then that one representative brings all five voices to that table. So it does vary. The more interesting thing that we've obviously got here is, as you've rightly said, we've got place as three separate local authorities as well. So we need to work really hard to make sure that the voices of the individual local authorities aren't then lost in the place and then at Bob level. It's the three Berkshire West Health Watch were commissioned separately, but because we are the advocacy people were successful in securing the contract across all three, what we can actually do is we can treat it a little bit more like place, and therefore that provides massive economies of scale. So I will go to one meeting like this week, the two lead officers and myself, we've all been at three different meetings at the same time, which you couldn't do as three separate. So yes, that's our experience. So we're trying, we're getting our feet at the table of these new meetings and things.
Super, thanks very much.
You're welcome.
Andy has one final question.
Okay.
It's a comment as much as a question, just to say that I think earlier in the meeting, Alice, Alison, who's not Alice, said, what do you think we should be looking at which could help you? And I think you mentioned that the dentist thing was very, very useful. I don't know if you're aware that we had a meeting, I think, at the end of last year, where we actually had we had representatives of GPs in. I can't remember if you're at that meeting or not.
Yes, I was.
Yes, I was.
Fine. Okay, just to say we've done that one.
Mm.
Yeah.
But I think in a lot of ways things have changed and moved on, kind of thing in NDR at the moment because of the workforce struggles. I mean, they are really planning to look at it differently. So they would. I think it would be nice for you all to know what their plans are.
Right, I think we're done. So thank you so much for your time. Really appreciate seeing you, and
You're
look
very
forward to
welcome.
seeing you again. Thank you very much.
Thank you.
Bye-bye.
Bye.
Bye bye. Next topic, I believe, is the KPIs. Is that going to be Matt or Wes? Wes, over to Wes.
Thank you. So in spirit, just echoing, is that me? I'll just quickly run through some of the highlights in the report by exception. So obviously there's 7 KPIs in the report itself, 5 of which are green, 1 is red, and 1 is amber. In terms of the first one that is red, it's the percentage of safeguarding concerns leading to inquiry completed within 2 working days. We've seen Q2, it's 54%, slightly better than the last quarter. And I know this would have been in previous narratives around the pressure that the safeguarding services experienced pre-pandemic around referral rates and out of scope referrals. Again, I'm sure was discussed previously, is the triage process that has been put in place, in which safeguarding concerns are triaged, and we are starting to see fruits from that process. So performance in December was a lot higher. It was 76%. So we believe that in Q4 that we are going to see a significant improvement in this particular indicator, and that we will be moving in a more positive direction. Other indicator on here that is amber is around the CQC registration and providers good and outstanding, which we talked about previously around CQC, and that's amber. I would say here numbers play a big role. We've got 26 older people care homes in the borough, 52 care homes in total. So if one care home goes to one particular way, it has a disproportionate effect statistically. So one care home equates to about a 9% change in terms of numbers. But we work constantly and closely with CQC for our care governance process to support that inspection regime. And I think other than that, there's a lot of green in here, which really reflects the current position that we're sitting. So if there's any questions.
Bill?
Thank you. You said that drop from green to amber was maybe one care home that has changed, or it's 15%. So that's quite a reasonable drop. Is that something that we were aware of and that's been rectified under the guidance and monitored with the council?
Yep, so we work closely with CQC regularly through our care governance process. So the care governance process supports improvement in provision prior to an inspection process, and they speak regularly. There's one theory, Phil, that we're good at it. We talk to CQC, so where there are these issues, CQC are obviously working with the provider, and I think we will regularly support those. Obviously, there's pressures on the sector, and we're seeing it, but we've not seen, as you see nationally, a lot of providers get into a lot more trouble than we're seeing in Wokingham, and so there will be change, but that will go up and down as providers are inspected.
Rebecca?
Thank you. Wes, looking at the data from the CQC, so 100% of our nursing homes are good or outstanding, but so we're way above the average in England. But why is it that with the domiciliary care we're below? So I know we're on 67, but actually we're below standard there. Can you tell us why? Because obviously there's a drop with residential. I know the difference between nursing residential and domiciliary, but what if you've got any feeling of the reasons for why that's happening?
So one hypothesis is that a lot of inspections happened during the COVID period were light touch, and now we're seeing more in-depth inspection. So that may be one causality in terms of drop in performance, because they're more in depth in terms of that. Specifically to domiciliary care and what we're providing. So there's as you'll know, there's different types of domiciliary care agencies, the ones we commission with, and there's the private sector as well. Our care governance team will be supporting all providers, but specifically focused on commissioned providers themselves. So there's pressures, I think, on the system that we're seeing across in terms of financial pressures, cost of living could have an impact. But specifically to domiciliary care, I can have a look at that and come back.
It would be good to see, because we are below the average in England, which doesn't really make, there's something happening in that there's something not working within that sector, whereas 100% of our nursing homes are. So yeah, it's just flagging something for me there. So if you could come back to us, that would be useful.
Can I just ask on that subject, if you don't mind, that was reporting figures from March 2020. So the figures that it's showing us in the table you've given us is that is now 90%. Does that mean that there has been an improvement since March 2020? Or are they looking at slightly different figures?
Sorry, a little bit more. Sorry, Phil, I'm not sure.
Page 31,
Yeah, it is.
in quarter 2, 22, 23, and in the bar chart that's showing the page says that we're at 90% of our domiciliary actual, which is against the March. I do beg your pardon, but that's 10% off for me. Page 31 states that our domiciliary care is at 90%, and that's reflected in the bar chart at the top of the next page. And that's for quarter 2, 22, 23, as opposed to the CQC figures that we were talking about just a minute ago of 67%, which was back in March 2020. So are they looking at the same thing? And so there has been improvement between then and now?
I'll have to come back to you on that, Phil. I'll have a look at it and come back to you.
I don't see a mention when we started to get reports from Matt Pope. Certainly, when I joined the council, we always used to have regular sort of updates on Ophthalis and its integration and how that was going. I can't see a mention of Ophthalis. Is there anything you'd like to say about Ophthalis?
Yep, in terms of Ophthalis and the way we work with Ophthalis is come on really strongly in recent years. I think culturally we've seen a shift as well in terms of the way in which we work with Ophthalis, and we work with them a lot closer. And there's some benefits that we get in terms of working with a strategic partner in that way, in terms of you don't have the same honest conversation with a provider in terms of types of care being delivered and how you can improve services. So there's a very soft benefit there. And we've also seen an increase in the amount of work we work with Ophthalis. So Loddon Court is a respite centre, which we recently transferred from one of our providers to Ophthalis as a new provision, and that's been running for a couple of months now. And again, goes from strength to strength as a provision. We're just about to start a refurbishment of that building, and looking to improve on that and improve residents or people's experience of being in that respite centre. And again, working with Ophthalis gives us that ability to identify those opportunities numerically in terms of how they're performing. We manage their contract, and we have a partnership meeting where we look at the data. It's very much focused operationally on things like voids and how we fill our contract and make sure that is performing as well as it can be. Yep, sorry, you're going to say something? No. Yep. Again, look at those opportunities for growth in terms of working together and working brilliantly. I think in this performance report, what you'll see is the indicator around people with a learning disability and those people that are living in their own home and with families. And you see that the performance has improved and it's got better. We're looking about 94%, and that again is working with Optilis about the type of care and provision that we work with. We have Hatch Farm, which is a specialist accommodation building that's just opened, and that's with Optilis. So we've seen performance improve through our partnership with Optilis.
Every meeting that I went to where the Chief Executive of Optilis presented, always presented a positive narrative, however, with certain caveats. Especially around staff retention and recruitment. Is that still an issue for Optilis, or is it, and the sector in general, or is this really more stabilised now?
Workforce is one of the major concerns in terms of adult social care generally, as it is nationally. Recruitment and retention is a big issue for all our social care providers. Optilis is no exception in terms of that. We'll have issues. We work closely with Optilis in terms of their contracts and how they encourage and engage staff within their workforce. And we work closely around their improvement program, how they take on overseas recruitment and how we can work in terms of employment there. However, it is and will continue to be a major issue for all adult social care providers across the sector.
I'm missing a KPI for autism, obviously. We're here today to talk about autism. I want to see that monitored somehow. Obviously, it's very early doors. We abandoned the previous autism strategy. We're doing a new one. We've got an FTE that's driving that forward. But I think we should get visibility on autism as a KPI in this deck. And the expectation would be, as we start to deliver services in this space, that we would be building from a low base. I would expect a red rating initially, and then hopefully moving to a better rating. Sorry, Alison.
Yeah, I just wanted to ask. It's very interesting to see the number of providers rated good or understanding in AS7. However, that's the only table report that simply has percentages. On all of the others, you've given us actual figures. AS1, it's 77 out of 142. AS4, it's 449 out of 518. It gives us proper understanding of what we're talking about. So I just wondered if we could be provided next time with how many nursing homes, how many residential homes, how many domiciliary care agencies there are. Because I know it goes on to say 3 of them caused the drop. I suppose I could have done the maths. Apologies for that. But if you could just put that in, that'd be great. Thank you.
You stole my question. I was going to ask the same question because one of the things that Matt used to talk about 2 years ago was 64 care homes, I think. And I think you mentioned 52 so the numbers seem to have changed slightly. I don't know if you'd like to comment on that.
Yep. So that number of 52 includes learning disability care provision as well as older people care home, and obviously it extends residential nursing home provision, etc. Now, the learning disability care home provision will often be in effect like a small house that people are living in, and it's more of an older fashioned type of care, and we're looking through our specialist accommodation project to move people into more supported living accommodation rather than a care home provision. So that number will change hopefully and go down. The 52 includes both those, and there may be multiple homes within that provider. So Ravenswood around the corner is currently 4 or 5 homes together, which will be 4 or 5 care homes, but that's within one complex. So the number is somewhat misleading, but it's both learning disability and older people care provision.
So where do you get the cap? Do you use the capex budget from where to create these homes, or do you rent these homes, or?
That they are private entities. We have one care home in the borough, Suffolk Lodge, which is run by Optilis, which is a residential care home. The others are private entities. They will be ranging from small family-owned businesses through to large corporate international organisations, and they will range in both quality and cost. If there's a large chandelier and there's a grand piano, there's a reason there's there. So we commission off a smaller proportion of care homes, and they won't all be in the borough as well. And it will be based on an individual's need and where we can discharge our duty based on cost.
Sorry for asking loads of questions. It shouldn't be my job. At the height of COVID, there were significant pressures on occupancy rates of some homes. And I know that if a home drops below, say, 85% or something, they essentially become unviable. So at that time, Matt was having kind of monthly discussions with the care homes that were verging on being non-viable. Are those discussions still ongoing? Do we regularly catch up and make sure that the finances of the homes that we subcontract to are still viable, and the owners are wishing to continue them as viable businesses?
Short answer is yes. We, in terms of provider sustainability, that's my responsibility, and we do a number of things. The first thing is we track occupancy level. That's done through a national system, and that's reported into our adult social care leadership team. So we keep a regular view on that. There is a caveat on that because a provider doesn't have to do it. It's done on good faith. There's a threat from central government that they will be fined. But in reality, they're private industry. So we work really closely with our sector around sustainability and how they keep going financially. And we work with them really closely. During COVID, there were sustainability issues, and we work with social care providers. I would say that that's in a different place now, but different challenges, workforce that was talked about earlier, cost of delivering care. And we know that adult social care is historically underfunded anyway, and that places pressure on the sector. And we work with care homes, but we know in the borough, approximately about 53% of occupancies is taken up by private funders as well. But we work very closely with the sector to support them and have regular conversations.
Again, at the Bob Hosk meeting today, there was discussion from around the ICB around their strategy, and they're fleshing out their strategy, and they're starting to reach out more and more to their partners. And one aspect of that is they want to define metrics and KPIs and all the things to capture the running of the ICB, ICP, ICS. Are you going to actively be working with those guys to maybe adjust some of your KPIs or adopt some new KPIs?
So in terms of health integration, there's some performance indicators that are managed through the BCF and the Wokingham Integration Partnership, which I'm sure Ingrid could allude to a bit more on. So there's a set of indicators that we work with already around hospital admission, avoidance, etc., through the WIP process, and we work very closely there with them. And in terms of the capacity within the sector, again, we work very closely, specific around hospital discharge and how we're managing hospital discharge in the local area. So we share performance regularly around that as well.
Any further questions from anyone?
Yeah, sorry. AS2 about social work assessments, that's now at 100%, which is fantastic. well done to everybody. Does that indicate that the problems that we had with recruitment and retention of social workers, that's hugely improved now?
There is still an issue with recruitment and retention of social workers, and we have a workforce strategy around supporting the sector, and we will continue to work on that. But again, that's a national issue in terms of the numbers of social workers that are available, pay and retention and reward. That will be an ongoing issue in terms of social care going forward.
So what's made the difference? Why have we hit the target this quarter? Going up from 79% to 100% is really good, but what's changed?
So there's been a concerted effort in terms of resource and the allocation of resource to support this indicator, and again in terms of how we're working with the hospital and utilising additional resource through the winter has supported that. But again, it doesn't go away from the fact that long term there's an issue in terms of the workforce that we're experiencing in social care.
So with the next quarter that you'll be reporting being the winter, should we be prepared to see that it will probably fall again?
I think given the pressure that the sector's under, it's really impressive that we've managed to do this, as well as the financial element that adult social care has been able to deliver on. So I think it is a real achievement. I think it may do in the short term in terms of the winter. There's an increased demand over the winter period, and the pressure on social care around discharge as well is there. Yeah.
This is going to be a really annoying question, and it's probably not really for you, but just to get people thinking. Whenever I think back to my first jobs 30 odd years ago, I think about responsible employers, and responsible employers find it easier to attract staff and retain staff. So there was a report requested by the Mayor of London, Sadiq Khan, which came out last week, I think it was, from a professor. And he said one of the big things that's leading to 1.5 million vacant job vacancies in the UK is the cost of childcare. So the cost of childcare in this sort of area is 18,000 per child. In Sweden, it is subsidised to be £1,500 per year. This means typically, this is not a sexist comment, typically the female partner, i.e. the mother, can go back to work because she knows she has employer or state subsidised childcare, and this can then attract her to continue her career, to gain further steps in her career, and also obviously be a part of the working community. So my question I'm going to ask everybody that I speak to in this council is, when is this council going to be a responsible council and have subsidised childcare so that male or female or whatever parents or guardians can come back to work and stay within the fold of Woking Borough Council or up Thurles and the social care sector, where churn is very significant. If you have subsidised childcare, I think your retention problems would be severely diminished. So I'm going to ask this to everybody, not just you, but the chief exec and the leader of the Liberal Democrats and everybody. If we are responsible employers, then people want to come and work for us. But I don't want an answer. I just want you to take away and think about it.
Yeah, I'd agree. And again, I think in terms of the workforce, again, in adult social care is under pressure. But again, adult social care is historically poorly funded nationally, and we would like to do more in terms of the workforce, but it's a difficult scenario in which adult social care is currently in.
Thank you very much. Thank you. Any further questions? Thank you very much.
Sorry, there was in terms of the management committee, there was some additional questions that was asked to respond to in relation to feedback at this meeting, if that's okay, in the performance report.
I've been ill, so I don't know.
Okay, so there was a specific question about the adult social care transformation programme and the scrutiny and oversight of that programme, and I can either in a future date come back and talk about that programme, or give just some headlines of what's on there. There was COVID-19 and the impact on performance, which I believe we've spoken about.
I mean, you know, there is a general push in this council to get much more proactive and get into what are you doing next, rather than we did this last year. So this is music to my ears. So I would strongly encourage Madeline to coordinate when you're available and when you can present this implementation strategy. I think it is. Yes.
Yeah, so we in adult social care we have a wide-ranging transformation program which varies from assurance and inspection, because we will be inspected from April next year, through to specialist accommodation, how we get more people with learning disability to live in their own home, and through to Optilis and development, the autism strategy. We have a program across, and I think there was just a question around from the management and oversight committee for us to respond to that question specifically.
Yeah, I think we just need to schedule it with you, Wesley. So take that offline with Madeline and we'll get that organised into the forward programme. That'd be great, thank you. A request from my side is, because I'm an ex-IT guy, I always want to understand the IT integration, because at every meeting I go to and every NHS person I talk to, they say IT is a massive problem. We are not integrated properly in terms of IT. So yes, I absolutely want to understand the critical business processes and the setups that you're going for, but I also want to understand the integration of the underlying IT infrastructure. And that's not just a navel gazing thing. It's, you know, how the hell are we going to work together across a massive 2.whatever million people in Bob if none of our IT talks to each other? So this is for me a critical question as an IT person.
Outside my skill sets, Adrian, but I can.
I don't want you to answer every question, but just get the right person in the room.
Sure.
With respect, Chair, you can have a conversation with me about that if you like, and I can bring you up to date. Not now, but you're welcome to do that, because I'm involved in the Connected Care programme, which enables the access to data right across the healthcare community in Berkshire. I mean, between various suppliers and providers.
I mean, this is an ask to you, Phil. You know, if you're willing to present something to this committee, I would definitely appreciate that.
I'm not going to present on their behalf, but I can bring you up to date where we are, and perhaps you might want to then ask them to come and then present on about it.
Yeah, I'm very open to that, and thanks very much for that, Phil. Hi, Ingrid. Sorry.
So it's just to say that I can take offline with Madeline, but there is a specific IT transformation work programme under the ICB. So it might be that we get someone from that who heads up that piece of work to come and talk to us about what's happening at the Bob footprint around their IT transformation.
Sorry, that would be absolutely super. Thank you very much, Ingrid. Any further questions? Any further points? Wesley, thank you for nearly answering every single possible question, and hopefully see you again soon. And we'll get you scheduled in to do that other talk, and I presume you'll do further updates on KPIs and things like that. And thank you so much. The next point is the forward programme, which I just think in the last hour or so, we've probably put about 6 items already in the forward programme. I if I remember last time I talked to you, Beth, we were talking about an item you wanted to bring to the forward programme. Did that get documented at the last meeting that I missed, or do you want to add that into the forward programme now?
I can't remember what it was right now. Perhaps I'll talk to Madeline about it later on. She might remember.
Okay, Beth. So really, this is. I think we're going to have lots of presentations, and I see a willingness to get us into that proactive mode of getting things before exec, of getting things in terms of strategy and ideas about implementation and moving towards implementation. So these are very good signs. We don't want to just look at rear-facing, this is what we did last year reports. And I would also say that there was a very good update from Healthwatch, which puts us in a better place than Healthwatch, which we obviously want a regular Healthwatch update. But is there anybody else who's got some brilliant ideas for the forward programme?
I don't know this is a brilliant idea. However, you and I and Madeline have been to a long way to a meeting today, and I wonder if we should be scheduling in some form of feedback from that, because I think that would be helpful for the members to know how that communication is working up and back down, and what their plans are for the Bob Hosk.
You're absolutely right again, Phil, and I completely agree with you. We do need to brief this committee. It's very early days for the Bob Hosk. We just elected a chair and we elected a vice chair, and we had some discussions, and the forward programme is yet to be defined and will be subject to changes at ICP level. So that will be a moving feast. However, one of the statements from the chair, and the chair is a very strong-willed lady who is, what's her name? Jane McBean. Yeah, she's a very determined lady, and she will not accept the kind of lack of communication that the Bob Hosk and Hosks in general have received from the ICP and the ICB so far. So she was very demanding, as was the other Jane Hannah, who's the deputy chair. They were very demanding on where is the communication? Where is the engagement with our residents? What are you telling our residents? What are you going to be telling them in the future? How are you going to be telling them? And really, the answers at the moment, really, if I can summarise, really weren't there from the ICB and ICP. So they are going to apply a lot of pressure in that area. And I think that fits into what we were talking about earlier on in terms of engagement with the residents and communication and everything else. And obviously, I mentioned already that they see Healthwatch as a really critical aspect, and they have very good engagement with their health watches. Another interesting aspect for everybody in this room is that Jane McBean said that they have the power to set up task and finish groups, and these are to be defined yet, but certain areas that can be regarded as basket cases, and one of them was named as, in the previous meeting, as NHS dentistry, as named as a basket case across all areas, that we would, at the Bob Hosk level, create a task and finish group to really delve into and challenge the relevant areas, whatever the areas for investigation are going to be. Now, what Jane McBean said, which I thought was very insightful, was they would be looking, whenever these task and finish groups are set up, to include all the relevant experts from all the different hosks. And for me, that doesn't mean just Phil and myself who attend the hosk on your behalf, but anybody that's particularly interested in a topic where there is a task and finish group being set up. You know, you could be invited and participate in that task and finish group if you put your name forward. I don't see there's any reason why we shouldn't do that. Sorry? Well, we'll clarify that topic later. I'm always talking a little bit beyond the envelope. We always need to push the envelope, I think. But so yeah, I think the future is going to be quite interesting, and I agree with Phil that when we have, I think we're anticipating probably 4 meetings, sort of quarterly meetings, that we, Phil, myself, potentially Madeline, give you guys an update on that meeting.
So,
please.
Would it be appropriate for you to share the minutes when you receive them?
Absolutely, we will absolutely share the minutes.
Thank you. Could I just check what you mean by basket case? Because I mean,
no, it was
the normal term is not normally used.
Yeah, so there was a discussion. This was the July 22nd meeting last year. There was a discussion from all HOSC committees concerning NHS dentistry, and I think it was Oxfordshire said, you know, if we were to summarise from our perspective, every region has a problem with NHS dentistry, and we would call it a basket case. I think that those were the words that were used by one. I think it was Oxfordshire at that meeting. I'm trying to be transparent and use the words that were used by them. I think it was we had a very, very open, honest discussion, and obviously subsequent to that, you know, we see the NHS KPIs in terms of ED and A&E and everything else falling away massively from the targets of 94, 95% to 60% or 55% currently. So there are significant challenges out there in NHS land since we had that meeting previously. Is there anything else I need to mention, Madeline? Anything else, Phil, you can think of?
Well, notice that the document that presented was a draft strategy for the Bob, which should align with the local place-based strategies. And that is going to be developed. That was presented by the Deputy Director, was it? The Deputy Director, and it's to be continued, but that strategy will be circulated as well with the minutes, I would imagine.
And Ingrid is responsible for one of the work streams. So, we are engaged on this, which is great to see. And we're involved in developing the strategy. It was very high level, and even things like the defined partners were undefined and not clear. And that was one of the questions that came up. So there will be a lot more fleshing out of the strategy and the metrics and the KPIs and everything else. Any further topics on anything? I think we've got quite a few things to put on the forward plan. I know we have internal discussions between the chair and the officers concerning the forward plan, and I would suggest that we send out a draft forward plan so that everybody can comment or put suggestions for the additions to the forward plan if nobody's got any comments today.
So what were we looking at on the agenda in March?
So in March, you had the update from the CHC. What I would say is that the meeting is being held in Purda, so that will potentially limit what we can look at.
Does Purda start on the Monday, the 27th?
I believe it will have started by the 27th.
So I was assuming it was starting on Tuesday, the fact that we're even having a meeting?
We can potentially look to move the meeting earlier if we think it's an issue, if it is in PERDA, if members would prefer.
Sorry, speaking from a town council perspective, we're already getting into this PERDA stuff, and a number of meetings are either becoming almost dead rubbers and things. So if this committee wants to move that meeting forward, then please tell us.
I think we should. I think we should avoid PERDA for everybody's sake, really, and get things out of the way.
So, Madeline, are you saying that PERDA begins, is the nominations open on the 27th of March?
Can't confirm the date, but I believe that the 27th would be in PERDA. If it is, would the committee like me to rearrange it so that it's earlier?
Is there anybody against?
I'm just thinking the rules around PERDA are so loose and unenforceable, unenforced. I don't think it makes any difference.
Sorry, Madeline, do you think there's any real PERDA questions with any topics that could be covered in March? Or can we just go ahead with that date? Okay, we'll discuss it and get back to you. If we need to move it forward, we'll send you an email. Okay? If there's nothing else, thank you very much, everyone.
Thank you. Good night, everyone.
So what we have on March is those that we have already and the further update from the CHC. I would suggest that those that are currently on the unscheduled list, that we move those into the next municipal year. Because
with South Central Ambulance Service, you know, they've been given a terrible, you know, that they're no longer, was it requires improvement? So I do think that is quite important to be looking at that, and whether we can have the update on the 2 medical centres and the autumn COVID booster plan. If we don't look at that until June, it's getting quite a long way away from it.
Mm.
Can we have some discussions and we get back to you with a draft?
Shall we agree to decide this as committee by email then?
Sorry, I didn't hear that.
Shall we? Are you going to discuss by email to agree what's on the next agenda?
Yeah, let's do that.
Okay.
If that PERDA topic is not really a significant topic for health matters, you know, let's try and get some, you know, 3 or 4 things in the March meeting that fit your requests, and move the other things into June, whatever. Okay, thank you very much, everyone, for the meeting. Good evening, good night, goodbye, safe journeys.
Good night.